we always say cell is the structural and the functional unit of life. And when we talk about cell, we are looking at the component of cell. But the most important component of cell is the genetic material. So now when we use computer and software to process DNA, to process protein, to process genome, when we say genome, we're talking about the total genetic makeup of an individual that now instruct growth of such organism, functioning of such organism, and reproduction of such organism. By the time we use a computer and software to process such information, then we're talking about bioinformatics. So what this session is about, we want to look at how we use computer to process information that we have initially entered, and we use computer to also process biological information. This session, this panel, will look at how that can improve our health system generally, and how that can improve our health care as a whole. Thank you.
Thank you very much, sir. Yes, ma'am.
Thank you very much. There is no need for us to keep repeating, trying to explain how artificial intelligence relates with bioinformatics, because it's the same thing even with nursing science. Nursing is involved in caring for people, even though we may not be doing too much of true experience, but we are also engaged in some level of experience. Nursing is not just giving data. We also have data, and it can tell us diagnoses, it can tell us interventions or type of care that we can give, personalized care to our clients. But much more than dealing with data, AI also can be very useful to us in physical activities, actually helping us to carry out tasks that could be burdensome for us, repetitive actions in the course of our work. So it's not just about data, but there are physical activities that AI can also help us to engage in our discipline. Thank you.
Thank you very much, ma'am. Dr. Fioluwa. Thank you.
Thank you very much. I look at this room and I see a lot of excited, energetic, zealous researchers. And so when the discourse around artificial intelligence and bioinformatics comes up, I look at people who want to solve problems, but must understand the intricacies, the challenges, and the regulatory framework that currently exists. The convergence between biology, medicine, computing systems, data cannot totally foreclose law, meaning that your use of artificial intelligence in diagnostics, in your magnetic resonance imaging, in documentation and data usage can mean that you will lose your license. It can also mean that you will lose the entire hospital, because some hospitals, practitioners, as well as health tech companies are folded up because of litigation. So the dimension is that there's a promotion of the concept, there's following the dimensions. However, the aim of having a robust panel is for us to be able to look at it from different perspectives, a collaborative approach towards the research itself, as well as a collaborative approach towards the regulatory framework. In the course of the discussion, we'll talk about how it affects the practitioner, how it affects the healthcare facility, and then for those of us who are in health tech and those of us, when we listen to the first keynote, for those of us who are going to be coming up with health solutions, we must be thinking about where is the regulatory framework that really protects this. Patient consent, data protection, amongst other discussions that we're going to be having. So yes, we're going to be looking at AI, we're looking at bioinformatics, we're looking at the synergies and the alignments of all of the functions, all of the tiny areas that are connected. But importantly, we're also ensuring that you are not just desirous, zealous to solve problems. You are protecting your capacity to keep your license, as well as the institution that you work for, and then improving knowledge. Thank you.
Thank you very much, sir. Dr. Obami.
Thank you, and I say a big well done to all the speakers that have spoken before me. As a matter of fact, they've almost they've said it all. Now, I believe we are all familiar with the concept of AI. It is a disruptive technology that is currently redefining service delivery everywhere and everywhere every part of the world. So every discipline, as it is now, wants to, in one way or the other, want to actually incorporate AI, because AI is the present and also the future. In particular, by informatics in itself is a collaboration among several computer science of them, logical is also being one of them, and the third one being statistics. So computer science, or rather bioinformatics, cannot exist or cannot actually exist in isolation, except having several experts coming together to actually work together to deliver the required system. Now, building an AI system, for instance. To develop an AI system, we would actually need a computer scientist who will be nothing but the knowledge, the technical engineer. He will be the system developer. But for him to develop the system, he needs someone who has an in-depth knowledge of the field in which he is trying to actually solve a problem. Who will be the knowledge engineer? In this instance, perhaps the person in life sciences who will then provide a data set, or perhaps give guidance on what the data set would actually mean. So without the working together of all these in harmony, they won't be able to actually deliver something that will give what is expected at the end of the day. Then also we have different models that could to achieve the final result. As part of the work of the knowledge engineer and that of the technical engineer, they will have to work together in ensuring that the stated objectives at the beginning of the work is achieved. So all we would be discussing in the course of our discussion. Thank you.
A round of applause for our panelists, please. Thank you very much for the information. Thank you so much. Summarily, Dr. Kiela talked about ethnicity being important in the data set. It will be very important to use the appropriate data set for the work to be able to get good results. So the ethnicity is very important. You also talked about collaboration. Also, Dr. Ifeoluwayimika mentioned collaborative approach, meaning collaboration is important to achieve this result. Dr. Oniide mentioned about data. Data is important for research. Data is important for you to be able to use artificial intelligence and get good results that you can relate with, not false positive or false negatives. You also mentioned about biological information, genetic materials, the DNA, which are key to bioinformatics. Dr. Cecilia mentioned about data, also interventions, and then how AI can be used to assist or help with repetitive actions that nurses do. Dr. Obami concluded by saying that a technical engineer and a system developer is important, because when you have your data, you need someone who is versed in the use of software programming to input the data, input the right commands, codes, so as to get the appropriate result, because it is also very important. Thank you very much for this informative session. So I would ask one or two questions, each of the panelists, and then they will have the Q&A to the audience. So please, I will start with Dr. Akimade. Dr. Akimade, thank you very much once again. Please, I would like to ask you, how can AI tools be integrated into medical and nursing education to improve learning outcomes?
Okay, thank you very much for the question. The question is how AI can be integrated into medical training, right? Okay.
Medical
Nursing
and nursing
medical
education
Okay,
to
so-
improve learning outcomes.
Okay. So, one thing I want us to realize, which I believe most of us already know, is that we are right the AI revolution. And the idea that some people may still get offended when students utilize AI may be a pointer to the fact that we are not being realistic about the AI revolution. AI is all around us. There's a very popular story about the first time cars were introduced to society. People stood against the use of cars. They preferred to use horse carriages. And one of the prerequisites for the government then to allow cars to go on the road was that before a car would move, a human being would be in front of the car with a notice board to say, "A deadly vehicle is coming behind me. Be aware." At that time, cars could move at about maybe 5 kilometers per hour. But now you have high-speed trains that can go at 500 kilometers per hour, all within 100 years. And the foundation for AI has been laid from about 50 years ago, actually, even from when the computers were conceptualized. So we're here now, and I believe that the progression of AI is going to be very rapid. So we have to stay ahead of it, or at least try to be at the same pace. So this is a sort of appeal to all of us on the different spectrums of our learning journey, from students to advanced researchers, that we have to understand that AI is here to stay, and it's going to revolutionize our thinking in many ways that we can't even conceptualize today. Think about 20 years ago, just 20 years ago, when we got cell phones in Nigeria. We had the popular 3310 Nokia phones. Most of us are not old enough to remember that. All right? So the Nokia 3310 phones could hardly send text messages. You had to type very slowly to send a text message. It was a Herculean task. Look at your S21s and your iPhone 17s today, and what you can do. Because of the iPhones, we no longer need cameras, independent cameras, calculators, and so on. That's how AI is also going to rapidly progress. Now, going back to our question, how can we inculcate AI into healthcare training? I think it's a very interesting area that we must look into critically, because we must make progress with the world. There's a concept of adaptive learning. Adaptive learning. Now, when you have several students in a class, not everyone is going to learn at the same pace. Everyone has different pace of learning. So what AI gives us is an ability to individualize or personalize learning. If you have an AI tutor, the AI tutor can identify your areas of strength and build on them. The AI tutor can help to identify your weaknesses and strengthen them. For example, as a student, I wasn't one of those that quickly understood the concept of things like ECGs. Even up till now, in fact, it's a popular joke amongst clinicians that orthopedic surgeons are illiterate when it comes to ECGs. When you look at an ECG, you just see wave lines going everywhere. But the cardiologists, they are well schooled in the area of ECGs. They can tell you a million things that are wrong with the patient when they look at an ECG. Now, the AI tools can enable you as a student to understand what an ECG is, what an arterial blood gas result means, even what an electrolyte and urea result means, and help you to extrapolate to see where that patient may be headed, so you can start to administer treatments ahead of time. So those are some of the things that can help to personalize the learning process. It also helps us to create scenarios. One of the things that happened during the keynote speech was that I think it was Professor Remosu. He mentioned, or one of the questions was about cadavers, and somebody came up with anatomage. Anatomage is a recent concept, or well, fairly recent concept, where you can have three-dimensional images of dissection processes. So you don't have to use cadavers anymore. You can have a table, and then you can flip through the different layers of the human body, kind of like cutting slices through. But with AI, you can even go further than that. You can generate scenarios. Let's say that you have asked AI to show you a three-dimensional image of the lumbosacral spine, for instance, and you are looking at the intervertebral discs. you can now ask AI to simulate a patient who has a disc prolapse and show you the symptomatology of that disease process. It ties up anatomy, it ties up clinicals, it ties up physiology, it ties all those things into one product. So that's a direction that AI can take us, and I think that it's important for us to start to look at how we can create the policies within which students and faculty can exist successfully in an AI environment, in an AI-enabled environment. So it's not an area where we should shy away and think, oh no, students are cheating with AI. No, let's form the policies, let's develop the guardrails, and let's make it a successful collaboration between humans and artificial intelligence. Thank you.
Thank you very much, sir. Thank you very much. Dr. Adeshaloni Ide, I have a question for you. How can bioinformatics improve disease surveillance in Nigeria?
All right. There are several ways by which bioinformatics can improve disease surveillance. I will share on 3 just because of our time. Now, when we say we have explained bioinformatics, there won't be need to refer to that. When we say disease surveillance, we are talking about how we are able to assess, measure the spread of the disease, which category of people are being affected by disease, the age, is it elderly, is it children, is it middle age, is there a particular gender that is affected by the disease, is there a particular occupation that is affected by the disease. When we're talking about disease surveillance, we're looking at the demography that are associated to a particular disease, as well as how the disease can progress, what has happened to different people previously affected by the disease. Bioinformatics can help in disease surveillance is one, we are able to come up with a model into the system and able to see which intervention is more effective and in which category of people. We may discover that if you give this particular type of drugs to this particular patient with a particular height and weight, with a particular complexion, with a particular comorbidity, then the outcome seems to be better. So it can help with accuracy in intervention, which will ensure a better outcome. Apart from that, it gives another problem that a lot of us can relate with is the fact that how you are being treated is so much physician or individual dependent in Nigeria. So it means if you see a very good doctor, you may have a better outcome. There are always good and bad in every profession. If you see the other one too, the outcome might not be as good as the previous one. But with bioinformatics, it will help to develop protocols easily. Like now, developing protocol is hard. If you get to a lot of hospitals, you realize that we don't even have protocols, treatment protocols. Different people in the
Let's look at how can AI influence our profession, the care that we give to patients. One, AI can help to enhance clinical decisions about our patients. For example, AI with information that has been provided about a patient, AI can give us alerts, warning a patient is about to develop prayer patient is to fall, can be alert. AI can give us alerts about deterioration about a patient's condition. So that helps us to make clinical decisions about that patient. Number two, major problem that we have in nursing practice that take our time is documentation. We take a lot of data, we take history, and we want to document. AI can actually take this off our shoulders, can help us with documentation, and this burden will be removed. For example, we can speak why AI when the nurse is not available. AI is available to chat and make clearances with our clients. In recent time, there was a study about online information, you know, about pregnancy risk, and a lot of women were getting a lot of information on online. We know that not all of this information is correct, but there's no one that is available to engage with these pregnant women to say, okay, what did you learn from the internet today? But AI can do this for us. Now let's talk about some of the challenges that we may be having. We know that we talk even right now, countries, a lot has been done or is going on currently when you talk about AI and nursing care, which is not the same as we have in Nigeria. One major problem, or one of the major problems that we have, is that AI needs digital information, technological infrastructures, which may not be going on currently when you talk about AI and nursing care, which is not the same as we have in Nigeria. One major problem, or one of the major problems that we have, is that AI needs digital information, technological infrastructures, which may not be, reliable here. We talk about internet connection. We talk about electricity. All of these are very, very important for AI to function very well in our system. And we know that we have challenges in this area. Apart from that, AI may be very expensive. AI, for example, we talk about robots that are powered by AI that can help the nurse to carry out some tasks, maybe to lift patients, maybe to change patient position, maybe to even run around like collecting supplies. This is very expensive. There is need for hardware, need for software, there is need for manpower training, and a whole lot of funds is needed for this to be powered. Now we want to ask, to what extent is our system ready to put in this money for people to achieve this? So these are some of the challenges that we have. And the digital literacy is very poor in our system. Both patients and even the healthcare workers. There are no facilities to enhance our digital literacy. And for us to be able to in our practice, we need all of this. Thank you very much.
Thank you very much, ma'am. Dr. Ifeoluwa, how should liability be assigned if an AI error harms a patient?
Okay, quick one. So this is about AI errors and liability, or assigning liability. Since you are not the one that did the error, then the machine should pay, shouldn't it? However, that is not the case. There's 3 categories of liability. It's a very complicated situation. So we have the 3 categories I mentioned earlier: the healthcare practitioner, or the worker you're talking about, the doctor, the nurse, or whoever is there. Machines, it is the collaboration of man and machine. So you cannot say that it is the machine that did anything because you are in control. Now, at the time when we get to totally autonomous procedures that will not require intervention, we might now be looking at what will happen with the or health tech companies. However, for healthcare facilities, the questions to ask will be, how much of a training do your staff have over the AI processes that you are using as an institution or as an establishment? Then, are there monitoring systems that you have as backup to be able to quantify? When you spoke about diagnosis, for example, we have a lot of cases in Nigeria now, and including before the MDCN, of wrong side surgery. And this is, at this time, we are currently using human administrative processes. At the time when we now begin to use non-human systems or AI systems, if you are dictating to your computer to type for you, and then you say left hand or left kidney, and then because of your tonation or because of how you have spoken, maybe you said, oh right, sorry, no, left, and then the person who does surgical intervention does an error. At what point are we going to be able to identify where the gaps have come from? So the three systems of the person, that's the practitioner in charge. Number two, the hospital or the facility. Then number three is the health tech company. Also on the two sides of the divide, both the students as well as the teachers. In the last few years, as an institution, we've presented a lot of technological innovations at different hackathons, where tech solutions have come to bear. We've gone for Zenith Alcoholics, we've had the Wema Alcoholics. In the past few weeks, we were supposed to have something with InterSwitch. We've not had many students from the healthcare departments or from the health sciences who have come up with solutions. When we go for these things, for example, we had last year or 2 years ago, some of the students from other universities who presented tech solutions that are related to healthcare. Some of them with detection, early detection. One of them was on breast cancer and detection. So working with the existing tech systems that exist in the institution, we're able to see the donors who are in the environment, but the students who presented it were from engineering, and the Commissioner for Innovation, Science and let me shock you. 1 year after, some students from another university in Nigeria presented it at one of their colleagues that we went for, and they were eligible for a prize money of about $100,000. That is where the challenge is. So you as a practitioner, you are at risk if you do not put the human in the loop. You cannot.
In the use and learning of AI, so that when you learn a new skill, you get a badge which you can post and display to everybody to let them know that, okay, in this particular area again, I am a professional. I am more than you in this particular area, which will also motivate others to go there. Then again, we know something about technology, that technology is always evolving. Technology is always evolving. Most of us now, if I ask us that how do we develop our presentation, majority of us will still say we use PowerPoint. And we have a number of people who don't even know how to use PowerPoint, even now. But now we know that technology has gone way beyond PowerPoint. We could have Gamma, for instance, that you upload a document on Gamma and within just a few seconds, a slide will be generated. We have other AI softwares that we could use to actually create interactive, interactive content. So continuous development, continuous learning is actually very, very sacrosanct and very needed in actually developing not just students but also staff to ensure that we have the required knowledge.
Thank you very much, sir. So summarily, artificial intelligence is a double-edged sword, but to what extent are we ready to embrace the use of artificial intelligence in our classrooms? I understand that at least our panelists have done justice to the use of artificial intelligence, but are we ready to embrace the use of AI? How do we teach our students to use AI, and to what limits, such that it will make them lazy in doing their academic work? Then what are the limitations? The fear of litigation, the fear of legal action is also in place. So these are the points from our panelists. There are tools that are actually very important. For example, the Turnitin is also actually very important for researchers. You want to check your manuscript before submission for plagiarism check. Yes, Turnitin is very important, it's very key. So we understand that there are good tools, artificial intelligence that we can use, but to what extent, at what point do we put a halt? These are my points from the panelists. So we have opportunity from the audience. Do you have any questions? Just one from the students, one from the staff, and maybe the postgraduate students. One from the undergraduate students, one from the staff or postgraduate students. Questions that you can ask any member of the panelists. Do you have questions? Anyone? Okay, sir. Please go ahead.
Yeah, thank you, sir. Thank you, Ma, for the discourse. So my question is on the use of AI vis-a-vis referencing in the research work. If you get information from any AI, how do you reference it? That is my simple question. And if it is not going to be referenced, then what is the fate of such information?
Thank you very much.
Thank you very much. Do you have other questions? No questions? Okay.
Okay.
No
None.
questions. Dr. Ifeoluwa Ayimika.
Okay. Now for research, and that's one of the major issues. Now, ownership. When a content, I was watching a movie. I don't know if some people, one or two persons will have seen the movie. And it's called I've forgotten the title. The Rookie. Where a guy was, an AI vehicle was being driven, and the AI vehicle basically just ran a red light. It ran a stop sign, but it was carrying a lady. So the police actually flagged the car, and the car stopped. When the car stopped, the police went there and wanted to give the driver a ticket. But on opening the door, there was no driver. So the police was talking to the girl the car was actually carrying, who was seated at the passenger side. That, okay, now I will have to give you the ticket. The girl was like, why would you give me the ticket? I'm not driving the car. Now, the police was puzzled. What do I do? Who do I give the ticket? Because I have to give somebody this ticket. So that is the problem with using AI or using generated content. It is not advisable to use generated content for your research. It is not an acceptable source. When you are searching, you are meant to search legitimate sources. Even Wikipedia is a crowdsourced platform. You can't use Wikipedia because information there are not reliable. Now, the generative contents are generative AIs like ChatGPT, for instance. What it does, it basically just go and scrub the web, get information from the web, and present them to you. So if I have a website or a blog, for instance, now, and I post on my blog that, okay, Buhari is still alive. Jubril was born. The guy that was buried is Jubril. Now, if somebody decides to prompt ChatGPT, ChatGPT can decide to actually bring content from my blog that Buhari is alive. Would that be true? No. Exactly, yes. So generated content are actually not advisable to be used for research. That's it.
All right, like in addition to what our last speaker talked about, it's important that we remember that the way we talk about hallucination in medicine, hallucination is when you are sensing what is not real. You are hearing what nobody else is hearing. You are seeing what nobody else is seeing. In AI, there's a concept of AI hallucination. So because of that, you cannot completely trust all information from AI. Especially, like what the speaker said, when talking about asking AI to generate the information for you, because it only follows algorithm and it look at similarity to your question and the information is bringing. So there are occasions of errors. Referencing should be done with referencing management software, not to impute your manuscript or your note and just ask AI to reference. If you do that, you can check. You will realize that there are a couple of citations that will not even exist at all. Now, if a citation is not existing at all, there's no point talking about if it is correct or not. So that once you bear in mind that AI hallucination exists, it will guide your mind on how to use artificial intelligence. Thank you.
Thank you very much, sir, Dr. Oniide. So we would like to conclude here. I would like to appreciate our panelists, Dr. Abuad-Cmhs, Dr. Adesholo Oniide, Dr. Cecilia Bello, Dr. Ifeoluwayemi Bamidele, and Dr. Stephen Obami. Thank you very much for your time, for your expertise in making this session very informative and educating. Thank you very much, sir. So I will call on Professor Ajayi to speak to the presenters and address them on how to go about your presentation, both oral and personal. Thank you very much, our panel. Take your leave. Thank you very much, sir. Thank you very much, ma'am. Please, a round of applause for them as they leave the podium. Thank you very much.
Good afternoon. So we are moving to the next session now. That's the parallel session, and that's the scientific session. So for some of us who have submitted our abstract, we are going to have three. So we have three venues for these sessions. The main auditorium here is the first venue. Then if you go to the first floor, we have the second and the third venue. So and we have the following people who will be sharing each of the sessions. In the main auditorium here, we have Professor Adekaye. Professor Adekaye will be sharing the section here, and then as the chairman, and it will be supported by two rapporteurs, and that's Mr. Shidera and Mrs. Duye. So you can stand up. Professor Adekaye, the chairman, I'm sure is okay. Professor Adekaye, they showed you of human anatomy. And then the second venue, we have Dr. Usarende. Dr. Usarende will be sharing the second venue, that's the first floor, room 2. And then Dr. Usarende will be supported.
Hello, can you hear me?
Dr. Usarende, are you here?
Hello? Hello?
Okay, I'm sure he's around. Maybe he's currently not in the room. So it will be supported by Ms. Fakunda, who will serve as a rapporteur. Ms. Fakunda, can you stand up? Okay, thank you. Then the third venue, we have Professor Loxin. Professor Loxin, you can stand up for recognition. Thank you, sir. And Professor Loxin will be supported by Mr. Daniel and Ms. Blessing. Mr. Daniel, are you here? Can you stand up? All right, thank you. So I will encourage us to just go to the front of the entrance. Here you can check your name so that you know where you belong. And if you go to the the second and the third room upstairs. You will see the name of the presenter there, and just check and know where you belong. So we are expected to break out now. And I was told that our lunch may be served in our various sessions. Thank you.
Hi everyone. So please, an announcement just to reiterate what was said before. Your lunches will be brought to you at your oral sessions or your whatever presentation sessions we are having. For those that are doing it here, they will bring them here. Those in the first floor, they will bring it to the first floor. Thank you, sir.
001 to 012. 001 for those that are presenting orally. Abstract code is 001 to 012. 001 virtual. Abe, blessing. You are expected to come online. Abe, blessing. You are expected to come online. Mr. Chidera. Is 001 Abe, blessing. Do well to come online. You are expected to be the first presenter. Okay, we are sitting there. Let's come together. Let's settle down, please. We are having 12 presenters here. 12 presenters. For this auditorium, we have Abe Ogungbe, we have Abiodun Ojo, we have Adebola, we have Ajayi, Adegoke, Sanusi, Oluwagbemi, Swande, Tanimore, Chuku, Oniyide, Adegoke, and Adegoke. Technical crew, which one are we taking now? The people that are presenting physically, can we have them here? Those that are presenting physically. Those that are presenting physically. If you are here, 1, Swande 2, so that we will not keep waiting for people online. Those that are presenting physically should go to the technical side. We want to see those that are ready.
Yes, I did.
O2. Yeah. So we'll be having O2 now. Let's settle down. I will give you my. Don't worry. The display.
I'm ready. I'm ready.
Hello. Okay. Right.
We want to take 001, which is virtual. We are expected. Abe, you are going to be given 10 minutes. 10 minutes. Abe blessing. Can we unmute? The first presenter will be talking on the cortical oligodendrocyte of juvenile Wister rats induced with varying concentration of intracisternal kaolin suspension. We need you to unmute so that we can listen.
Good afternoon. Good afternoon. I'm here.
Hello? We can hear you
Good
now.
afternoon. I'm here.
You, you are given 10 minutes to make your presentation. You can start. You can start now.
I can see my slides.
Go ahead.
Can I talk without seeing my without sharing my slides?
Share your slide and go ahead.
Yes, please. I'm trying to share my screen. I'm on it. I'm on it. Yes, I'm seeing my, but I can't share the slides.
Just go and click on the link there.
Yes, I'm on it. Yeah, I'm on it. I'm on it. Can you see my slides, please? But what's on now? Okay, okay, okay.
We can
Thank
see
you.
your slide now. Just enlarge
Please,
it.
can I start? Okay. Good afternoon, everyone. I'm Abuad-Cmhs from Anatomy Department, City University, and I'll be presenting on cortical oligodendrocytes of juvenile Wister rat induced with varying concentrations of intracisterna kaolin suspension. I'll be following this outline for the purpose of my presentation. Hydrocephalus is a very common neurological disorder that is usually caused due to accumulation of cerebrospinal fluid within the brain ventricles. This leads to enlargement of the ventricles and exert pressure on the brain. And this condition can result to brain damage or axonal damage. So the picture on the left shows the normal brain, it shows the brain with the normal ventricles, while the picture on the right shows the brain with enlarged ventricles putting pressure on the brain due to hydrocephalus. Kaolin is an aluminum silicates, which is usually induced via the cisterna magnum and is actually the most common way, is the most common chemical used in inducing hydrocephalus, which has been proven to be successful in animal models such as rats, mice, pigs, and so on. What it does is to induce an inflammatory reaction and fibrous scarring in the meninges and leads to an obstruction in the passage of cerebrospinal fluid, and this can cause the ventricles to enlarge. Oligodendrocytes are microglia cells. They are round cells with darkened neurons, and their dysregulation could lead to reduced myelation and dysfunction following hydrocephalus. There have been different studies on the effect of hydrocephalus on different regions of the brain. However, seems to be positive learning or research on the effect of different doses of kaolin on the molecular and outer granular and pyramidal layers of the cerebral cortex of juvenile rats. Therefore, this study aimed at examining the effects of hydrocephalus on the molecular and outer granular and pyramidal layers of the cerebral cortex of juvenile rats following varying concentration of kaolin, while objective includes to determine the effects of varying concentration of kaolin on the histoarchitecture of cerebral cortex and the morphology of the oligodendrocytes in the layers 1, 2, and 3 of the juvenile rats. A total of 18 juvenile rats was used for this study. They were grouped into a control group and 5 experimental group, which had 3 animals in each. They were acclimatized for 2 weeks and allowed to free access of water and feed. Ethical approval was gotten from UCT University. The rats in experimental groups, they were given 0.02 ml of 50, 100, 150, 200, and 250 milligram per ml of sterile kaolin respectively, while the control group had sham injection. This administration was done once. Their biweekly body weight was taken and recorded. At the end of the first week of post-induction, the animals were sacrificed via intracardiac perfusion, where their brains were dissected out, fixed for 2 days and processed, then stayed with hematoxylin and eosin for the evaluation of the oligodendrocytes of this cortical layer. Data were collected and expressed as mean plus or minus standard error of mean. P-value less than 0.05 was considered significant, and results were presented in forms of photographs and photomicrographs. So this is the result of the photographs of the animals, and this shows that hydrocephalic animals they had loss of weight. B and C are the hydrocephalic rats, while the A is the control. The hydrocephalic rat had unshaped back as seen in the red arrow. The horn barrow is pointing towards the hunched back of the hydrocephalic rat, and also flat placements of the lip, which is pointed as the black arrow, compared to control, which looked healthy and normal. Then the D is showing the biweekly body weight of all the animals, and this shows that all the hydrocephalic animals reduced in weight during the first week of induction, but from the second week they started increasing in weight, but their increment in weight never matched up with that of control, which increased in weight from the beginning of the experiment till the end of the experiment. So these are photo micrographs of H&E section cerebral cortices of all the animals, and this shows that there is a mild disorganization of the laminar cytoarchitecture of the neurons of hydrocephalic rats induced with higher doses compared to those induced with lower doses and even the control. While these are photomicrographs of H&E sections of layer 1 of cerebral cortices, or that the animals in control group had numerous LD active oligodendrocytes and very few degenerating oligodendrocytes compared to the hydrocephalic groups, which had more of degenerated or degenerating oligodendrocytes. And even the ones with There were the rats that were induced with higher doses of this drug, they had vacuolated neurons. The same thing goes for the photomicrographs of the layer 2 and 3. The group under control showed more or numerous healthy oligodendrocytes compared to the hydrocephalic group, which had more of degenerated neurons, and even vacuolated neurons were also seen in the animals given higher doses of kaolin. So the body weight changes noted under hydrocephalic group, being that their weight reduced in waist during the first week and increased from second week but never matched up to control, is similar to the findings of previous studies. And the results gotten from the H&E stain section, which is the mind disorganization observed in the central architectural pattern of the cerebral cortex of animals given higher concentration of kaolin, also support other studies. Oladapo et al. Found out that disorganization of the cytochrome pattern of kaolin-induced rats corresponds with the degree of ventriculomegaly. And Catalo also had reported that the cytoarchitectural pattern of these rats, the hydrocephalic rats, showed evidence in destruction, especially in the animals with severe ventricular enlargement. H&E stain sections of layer 1, 2, and 3 of the cerebral cortex of the animals revealed numerous healthy large and active oligodendrocytes compared to the control, which even had vacuolated neurons at higher doses. Ayanuga itself reported that they observed something like that as well in animals induced with 200 mg per ml of kaolin. However, there's limited studies on the effects of different doses of kaolin concentration on animal studies. In conclusion, the findings of this study demonstrated that kaolin is critically responsible for extensive morphological alterations of oligodendrocytes in kaolin-induced hydrocephalus in Wister rats, and it was observed that rats induced with higher concentration of kaolin presented more degenerated oligodendrocytes, even with vacuolations, compared to the lower concentration. So these are my references. Thank you.
A round of applause for Abe Blessing. Abe Blessing has delivered some of the things that they have been doing in their lab. Cortical oligodendrocytes of juvenile Wister rats. We will entertain one or two questions. The postgraduate students, the final year students, also the faculties. Blessing, you should sit back and listen to one or two questions before you go. Do we have any question? Kaolin induced hydrocephalus in Wister rat, juvenile Wister rat. Do we have questions? Questions from students that are planning of carrying out one research or the other, or that has been doing a research. Do you have any question? We are expected to ask questions. If after the presentation we do not ask questions, it's either we are saying completely we understand everything or we do not understand. Either of the two. Out of curiosity, we're expected to ask questions. Sabiu.
Good afternoon, my lecturers. Good afternoon, my senior colleagues. My name is Sabiu Balasoja from Human Anatomy. Thank you, presenter.
Hello.
Thank you, Ms. Blessing, for the good presentation. I have 3 questions with regard to your results. is there any statistical figure that you can show us, any bar chart and whatsoever, that show the effect of weight changes? But you just show us the image of the rat that signifies or that signifies changes with regard to the experimental rat. But you have not shown us the statistical data that show or that objectively shows the change in weight. And secondly, is there any? How do you know that there is histomorphological changes in the H&E micrograph that you have shown? Is there any statistical tool you use to identify, to indicate that there is significant histomorphological changes? And also number 3, how do you can you recognize any changes with regard to oligodendrocyte using H&E only?
Abe Blessing, are you with us? Can you hear all the questions? Abe Blessing. Statistical p-value to be p less than 0.05, but we are saying there is no empirical data to confirm that some animal had loss in weight, either in table or in graphical form. Why we will not want to wait, since we have close to 12? We will close this section. People can go and note some of those things.
Can someone help me to type? Maybe I can read and answer the question. I can't hear anything very well.
Can you hear me?
I can hear you, but there.
Okay, the question is number one. You did not give values. How do you confirm to us or convince us that animal induced with kaolin, having been confirmed with hydrocephalic or hydrocephalus, experience loss in body weight, since evidently we cannot see any table of values or graph between control which compares to some of your treatment group? Then how do you also confirm using H&E that there were some loss or some factors affecting the oligodendrocytes? We will stop at that while we call on the second presenter. Please, some of those questions, before you go ahead, just go and find answer to it. People that are here seated, you can also be looking at some of those things. When you present, you need to give information to back up your results well, so that people can be convinced. Thank you. Second presenter, please. Second presenter. Thank you. Have a blessing.
Okay. Thank you, sir.
Good afternoon, professors, doctors, and everyone here. All protocols duly observed. My name is Anozie Sophia Ifechuku, and I'll be standing in for Dr. Abiodun Ojo Esther, who is unavoidably absent. Today, I'll be presenting on a topic titled Nursing Students' Perception, Knowledge, and Coping Strategies regarding patients' deaths on their mental and emotional well-being at Afebabalola University, Ado-Ekiti, Ekiti State. Do you know that nursing students need therapy? Do you know that nursing students are taught how to handle emergencies? Yet, patient death is a reality many of us struggle with silently every day. The experience of patient death is a profound event for nursing students, significantly impacting their mental and emotional well-being. Research has shown that nursing students have negative perceptions towards patient death, and this is due to inadequate training and knowledge of end-of-life care. Aside from inadequate training and knowledge of end-of-life care, we also have other factors such as cultural factors. We have students from different nationalities, with different cultures and traditions regarding the death of patients. We also have students with personal fear regarding death. We have nursing students who have lost family members, and when they are faced with these situations remind them of their trauma. It triggers this trauma, causing anxiety and emotional distress in these students. The aim of this research is, number one, to assess their perception towards patient death. Is it negative or is it positive? To assess their knowledge on end-of-life care. And lastly, to assess their coping strategies, because experiencing patient death is inevitable. So how do they cope with these situations? How do they move forward from these situations? Do they just experience it and move on with life? Do they have adequate coping strategies? How exactly do they handle the situation? Now, in the course of this research, a descriptive cross-sectional study was conducted among 246 nursing students. And the questionnaire used was self-designed, and it had 4 sections, including the socio-demographics, a section which assessed their perception, another section which assessed their knowledge of end-of-life care, and their coping strategies. It demonstrated high reliability with a Probac alpha of 0.8. Now, the results. The findings revealed that most of the respondents were between the age of 20 to 29 years old. Most of them were female from the Yoruba ethnicity, and they were mostly Christians. Aside from this, based on the perception, as you can see here, you can see that most nursing students have a negative perception towards patient deaths. And from this category, we assessed their perception based on sadness, helplessness, and crying. And we had a high percentage
from the audience. Question. We have question. One. We'll answer two. How many questions? One. Just only one. Two. Then three. Then I have 4. Making 4 questions. 4. Very interesting topic that has been well researched. Do well to tell us your name and where you are coming from.
Okay. My name is Okerika Ife, a technologist in pharmacology department. I just wanted to ask about picking of the students, that's the sampling of students for this work. Was it just done randomly, or the students were picked from a particular level? Because I want to believe that the way a 400 level student will react to death, I think it will be different from the way 200 level students will react to death. So that is why I'm asking.
Did you get the question? Second. Okay.
Okay.
Thank you for that wonderful presentation. My name is Aguchidera. So my question is, from this study, can you highlight the best coping strategy? Can you let us know whether it's an emotional based or emotional focused strategy, or is it a problem solve coping strategy? So which of them was highlighted in this study? Yes.
My own question, I wanted to know, you mentioned student perception. Just in collaboration with the first and the second speaker that asked question, the people that will be going, what category of people in nursing do we see in this particular research? And I need to know, because carrying out the research, hospitals are expected to be mentioned. The perceptions will be when they go for posting, I guess, at a particular, so those area, the way people that are in the emergency, where they see that frequency of patient coming may likely be different from other units, maybe intensive care and the other one. So you try as much as possible to throw more light into some of those specific areas that you look at for the question attaching to those category of students that were involved.
So for the first question, the students, we used simple random sampling, and the students used for this research were between 300 to 500 level. And then based on your question, based on the results, the coping strategy that had the highest percentage was praying, which was 49.2%. Yes. Emotional coping strategy. Yes, sir. Then for your last question, so in nursing, we used Afebaola University because in nursing, like 100 level students, they don't do posting at all. Then 200 level students, they only do posting in their second semester, and it's just on Fridays and during the long holiday after the session. So during the period of this research, the people that were actively involved, or people that we were sure that had experience, were students between 300 to 500 level, because between those levels the curriculum is different. We have 4 weeks of classes, 4 weeks of posting, 6 weeks of something like that. So we believe that they had more experience, and the way they divide us of posting is they make sure we are in every ward. Like every student must have had experience in A&E, GOPD, so we are sure that our results will be reliable based on that. Okay, so in terms of cultural belief, for example, Hausa, like based on, oh, you can. No. So just like part of the explanation, but like based on cultural belief, we have different cultures. We have like Hausa people. They are not really, in terms of being, they are not really expressive. Like. No. No, okay.
A round of applause for Dambata. We call on the next presenter. Next presenter. The physical people, we want to take them first. We took so much time fixing people virtually. So let's take the physical so that we know we are moving instead of just physical. Ajayi. Ajayi. Adegoke. Adegoke. Are you here? Okay. Adegoke, sir. Adegoke. Physical. Adegoke. J. Ige. We want to take so that we know we have moved.
Okay. Good afternoon, everyone. Okay, so I'm Adegoke John Dolao, a registered nurse and a 500 level student of Federal University, Oye Ekiti. Okay, so I will be presenting a work titled Medication Adherence and Self-Management Practices among patients with type 2 diabetes in Federal Teaching Hospital, Ekiti. So I believe everyone will agree with us that medication adherence is the core management, is a core principle when we talk about managing any condition, particularly a chronic condition like diabetes mellitus. However, beyond the medication adherence, patients also have to own the management you are trying to give out to them, which is where the self-management concept comes in. And not to assume that everyone knows about diabetes. Say diabetes is a medical condition that is characterized by high level of blood sugar, high level of sugar in the blood, which can be due to the inability of the body to produce insulin or the inability of the body to make use of the available insulin, which is how it is categorized based on type 1 and type 2. This work focuses on type 2, and globally, let's look at the statistics. We have 537 million adults globally. Then let me just rush down to Ekiti, where we have about 6.5. Luckily for us, there is an available literature on the work that has been done in Ekiti, specifically on type 2 diabetes. And in Ekiti, we have a prevalence rate of 6.5% by Oluwadia et al. 2023. Okay, so this study was carried out in Federal Teaching Hospital, Ekiti, their endocrine clinic, and the specific objective is to assess the medication adherence among patients with type 2 diabetes, examine the self-management practices that they adopt, as well as the factors that influence this self-management practice. The method used was a descriptive questionnaire design, and we recruited 96 patients generally. That was due to the available patients, because it's, on average they have an average of 32 patients per week. So during the course of the research, we runs for 4 weeks, we were able to get 96 patients in total. And the instruments used was a standardized questionnaire adapted from TV work. We have a standardized MMAS 8 and self-management questionnaire, and then also an adapted questionnaire for Webe et al. 2011.
So the research was inclusive to patients who are above 18 of age, and then exclusive to patients that are cognitive impaired. Though they meet the inclusion criteria, but however, they are cognitive impaired or they are not available at the point of data collection. So right down to the results. The result of the social demographic data, which was based on our first instrument, section A, was well in alignment with the underlying knowledge of diabetes, which is more common to female. You can look at it, and also common to old age. It is obvious, like it is evident in our results, where we see 21 to majority of the patients, about 61 to 96 patients are above 40 age, above 40, and that is well in alignment with the underlying knowledge of diabetes, that is, it is common in old age, specifically type 2 diabetes. Now, moving to the medication adherence, there was actually, however, a paradox in the medication adherence level. It was observed that patients are adherent to, just rushing to the overall, patients were adherent to medical tasks like taking their medications daily, their adherence to it. However, when it comes to lifestyle tasks like diet, exercise, which are a core management of diabetes mellitus, they are not adherent to it. When you look at it, 47.9% admit they sometimes forget their medication. Then they also, it was observed in the result that 84.4% of them take the medication before coming to clinic the second day. That was yesterday. They had 84.4% before taking their medication yesterday. However, in the self-management practices, okay, yes, this is like a graphical representation of what we have. This is a pictorial representation. We have taking medication, keep appointments, check blood sugar. Those theories are related to medical tasks, as it is. Why they do physical activity and follow diet, they are related to lifestyle modification. Patients were deficient in that region. That was what the result is all about. Then for the self-management practice, the self-management practice is now, okay, factors that influence the self-management practices. We have lack of finance as the major one. We have which is under economic and logistical challenges. It is the greatest variable. About 39.6% of the respondents picked lack of finance as their major factor that is influencing their access to medications and their self-management practices. Also, we have inaccessibility to medicine and side effect of drug. And then it is concluded that financial hardship is dominant and motivated barrier that hinder medical adherence. Now, there was an hypothesis before the work, which is like there is no relationship. We tried to know whether there is a relationship between the patient adherence level and the knowledge of their glycemic targets, and there was no significant relationship between the two because the p-value gotten was over 0.005. So the null hypothesis was accepted. The second hypothesis is that there is no relationship between the adherence level and the patient level of education, which was collected during the socio-demographic data. We realized that majority of the patients that are not even taking the medications are tertiary, people with tertiary degrees and beyond that. So there is no relationship between the adherence level and the level of education. Now let me just rush to conclusion. This study concluded that medication adherence is not a knowledge problem. Rather, it is a problem of concept. Because when you look at one of the factors that influence the self-management practices, majority of the, let me go back to the slide. Majority of the respondents agree that they stop taking their medication when they are no longer feeling the symptoms, thereby treating diabetes mellitus like an acute illness, whereby you can just stop taking medications when you feel like you are not feeling the symptoms of high blood sugar. So majority of them stop taking the medications because they are not feeling the symptoms, and that is showing us that the problem that we have with medication adherence is not about their knowledge, but about a general misconception of what the disease is all about. Also, it was observed that majority of them are there with medical related tasks, so they just feel, okay, if doctor said I should take this dose, I'm taking it, then I'm okay. They are not like, they didn't embrace the intervention like it's for them. They didn't carry out the exercise, diet. They all agree that they are not following it. All right, recommendation is that the suggestion and recommendation is that this work can still be developed on by carrying out the research work was a quantitative research, so like recommendation is that a qualitative research can be done to like discover and have a in-depth interview to know the specific belief and reason of the 56.3% of patients who stop taking their medication, which would help in designing effective educational counter messaging. And also an interventional study could be designed to test the effectiveness of a new barrier-focused not intervention, which includes financial screening. Also the medical, the clinician, physical um, talking about the physicians now, when they are prescribing the medication, for majority of the factor that affect the adherence is lack of finance. So this study recommend that when taking history to like before you prescribe any oral hypoglycemic agent, we should consider the patient's financial status to know whether or not they can actually afford the medication we are prescribing for them. Thank you.
Question from the students. Students, questions? Chidera.
Thank you for the beautiful presentation. However, when you said that...
Your name,
sorry,
please.
I'm Adegoke Juliet, a postgraduate student from nursing department. I want to say that when you said diabetes was not a knowledge problem, the adherence from your results was not a knowledge problem. From your findings, that people are saying diabetes could be acute, it will go, that's why they are not taking medication. I still want to believe it's knowledge problem. Because if they had good knowledge of the disease condition, what are the do's and don'ts of the disease condition, they will adhere with the medication.
Really have a question. I just want to commend you as an undergraduate, and you are able to present this way. I think I am impressed. Well done.
People that wanted to present physically should meet the technical people so that we know those that are available around. I don't want to be calling, please meet them, they will synchronize it together.
Good afternoon, everybody. Good afternoon, the professors, the doctors, and my fellow students. My name is Alima Timlola Sanusi, and a 500 level nursing student of Department of Nursing Science from University of Ekiti. I did this project for my research work for registered nursing exam, and I'm here to share the results with you. The topic is awareness and preventive practices against skin cancer among clinical nursing students in Federal University of Ekiti. So cancer is like one of the major problems we are facing now, and despite a lot of work being done on it, they are mainly focused on the prevalence ones: first, breast cancer, lung cancer, prostate cancer. So skin cancer is also rising due to the depletion and exposure to UV rays, and so many people are unaware about these risks. So I decided to carry out this research, particularly nursing. I decided to carry out this research on nursing students, particularly clinical nursing students, because they serve as the people that would educate other people on these risk factors and how to prevent it. And we can all agree that there's no way we can teach what we do not know. So the objective is to assess the awareness and preventive practices against skin cancer among these students. And the specific objectives were to assess the level of awareness, to identify the preventive practices that these students practice, and to identify the factors that influence these preventive practices. So the method used was a descriptive cross-sectional study that assessed 206 clinical nursing students through 300 to 500 levels, and data was collected through a structured 30-item questionnaire. So the results, the socio-demographic characteristic of the students, most students came from 400 level, and this was due to the usage of the stratified random sampling technique. So after finding out the general population, I divided them into strata, which is their levels. They are 300, 400, and 500, and then divided the total amount among them so that each group will be properly represented. Then they were mostly females, mostly Yoruba, and in the questionnaire there was a question about the most prevalent skin color. What is their skin color? And it was mostly dark skinned people. So under awareness, which was the second section in the questionnaire, most students have a high level of awareness. Of course, they know what skin cancer is. They got most of their information from social media and medical school. They know the types of skin cancer, where it affects, and also their awareness level was high, even at a result of 81%. But the preventive practices were significantly poor. Most of them do not have the knowledge about what to do to prevent these risks, to prevent the causes, sorry. So only 3.9% have undergone professional screening, and most of them do not know that there is even something like that. And the resulting score was 46% level of preventive practices, mainly the usage of sunscreen, wearing sun protecting, wearing long clothes, long sleeves, staying in shade during sunny days. And the major barriers that affected most students that know about this is the high cost of sunscreen, which is 91.2%, fear chemical reactions, misconception that darker skin offer protection, and cultural belief that sunscreen is feminine. Most of the male respondents picked this. So, child screen analysis revealed the significant relationship between awareness and preventive practices. So, in conclusion, the study shows that despite high awareness levels, preventive practices remain suboptimal due to socioeconomic, cultural, and perceptual barriers. So, recommendation includes integrating skin cancer education, more of it into workshops, seminars. It is a different thing to know something theoretically and be able to practice it and be able to teach people through the knowledge. Then it contributes valuable insights for developing interventions to improve skin cancer prevention among future healthcare professionals. Are there any questions?
Questions on awareness and preventive practices against skin cancer among clinical nursing students in Federal University, Oye Ekiti State. The presentation is open for comments, observation, and she even demanded for questions. Skin cancer. Let me. Hello. Your sample size. What was your sample size? 200. How did you get it?
206.
How did you get your sample size?
I used a formula, Taroyami's formula, to get the sample size for the entire population.
Use your mic.
So the 300 level students, 400 level, 500 level, their total number was about 426 or so. So using the formula, I got 206 for the total population. Then I discussed earlier that I used stratified random sampling technique. So I divided the levels into strata to 300 level, 400 level, 500 level, and about 68 respondents from 300 level, 104 from 400 level, and 38 from 500 level.
skin cancer education. If I get one of those recommendations, should be included in nursing curriculum. The nursing faculties are hearing.
No, there is, but more like emphasis.
No, as an anatomist, we will start from the epithelial tissue, and we will also mention skin, and we will go to applied anatomy, skin cancer. But now you are looking at it from the clinical angle, which they are hearing, and you can see the media, they are also capturing. Thank you. You may go to your seats.
Thank you, sir.
Assessment of the perceived effects of social media and smartphone addiction on mental health and academic performance of students, nurses in Benue State. You have 10 minutes to deliver.
Good afternoon of the chair and the rapporteurs, lecturers, my co-participants and students. I am Swanda Ephraim Sawa, presenting on the topic, assessment of the perceived effect of social media and smartphone addiction on mental health and academic performance of student nurses in Benue State. Permit me to start by saying social media is the digital heroin and cocaine, while the screen is the digital syringe. All of us seated here, I believe we have Android phones or smartphones, and we are on various social media platforms, either Facebook, Snapchat, IG, TikTok, mention them. There has been a kind of a dissociation between physical contact and between people, because everyone that is either engaged in social media or smartphone distance themselves from the people that are within them. So it has a way of taking people that are closer, far away from each other, while bringing people that are very far away closer to each other. It has reshaped the way we interact, the way we associate with others. Social media and smartphone has reshaped that. It is as a result of this that I decided to carry out this study in order to deep and then look into it to know what actually is going on. In 2022, there were 4.95 billion internet users, 4.62 billion social media users, 5.31 billion internet users. In 2014, over 6.8 billion people were using smartphones. That represents 85% of the global population. Now, students are the major users of what? Social media and smartphone. Even as this lecture is going on, you turn around, you see many of us are busy with our smartphones and social media, maybe on social media, not paying attention. So this actually can affect the academic performance of students as well. So it has become a growing mental health concern. Actually, addiction to social media and smartphone. A multi-stage sampling techniques was used, incorporating stratified sampling, purposive, and random sampling technique to select 276 student nurses cut across 3 different institutions that are offering nursing in Benue State. Analysis was done using SPSS version 27. Instrument was adapted structured questionnaire from like the social media skills, the smartphone addiction skills, and then the mental health aspect of it was measured using general questionnaire 12. Results. You could see out of the 272 students that were used, 44.9% agreed that they use smartphone classes. Classes are going on, they are busy on their smartphones and social media. 82% admitted that they submitted assignment late because of what? Excessive social media use. As I'm talking, I believe some of us are judging ourselves and are scoring ourselves that whereas I'm victim of this particular aspect of study. 42.8% procrastinated. I have an assignment, yet the prompt on social media, okay, let me check social media for a few minutes, and then before you know, you want to do it for 10 minutes, you do it for 30 minutes, 1 hour, 2 hours, and the assignment that you're supposed to have done to submit is busy waiting for you. You procrastinate. Now, coming to the mental health effects of social media and smartphone on students, you could see sleep disturbance was reported that 48.2% of students experience sleep disturbance. When you use social media or smartphone, especially the pattern that is used at night, when you use it for a longer period of time, you keep yourself awake. It will come to a point that you will not be able to sleep well for that night. The next day, you are going to class. So it affects their sleep pattern as well. When you are supposed to be awake, you alter the words, the sleep cycle, the sleep-wake cycle. When you're supposed to be awake, you are busy dozing off while classes are going on. Then some also reported, about 26.1 reported that due to social media, they experience depression. Why? Probably, for instance, for those who are social media friendly or who are content creators or are influencers, I post something on social media, maybe after 24 hours, coming to check, I see only 1 like, only 10 views. And then someone, a friend of mine, posted within 2 hours, and you're seeing about 1,000 views. That could affect you. Oh, why is it that? It means I am not loved by my followers on Facebook. So that could actually create a pattern of depressive mode in the person involved. Then some also compare themselves negatively with others due to what? The use of social media. You watch people on social media posting pictures, having slim stature, and you're not slim. And then you compare yourself, I wish I'm also slim. That can also bring about other issues like eating disorders as well. Because you want to also maintain that stature so that you will not be fat. And then you start avoiding or skipping your diets. So it affects that. Funny enough, because it is a cross-sectional research, self-reported data, subjective data, about 80.8% rated their mental health as what? Good or very good. Despite reporting that, okay, I have depression or I suffer from sleep disturbance, yet they reported their mental health as good. In conclusion, student nurses demonstrated clear behavioral and addiction, academic disruptions, and sleep concerns despite perceiving their mental health as stable. So what is the way forward? We need to what? Focus on digital awareness education, structured device use policies, not only in nursing schools, but in other institutions as well. Because the trend or the pattern in which this is going is becoming alarming. So thank you for listening.
questions? Questions?
Thanks for good presentation, Mr. Swande. I was expecting you to carry out this research and compare between this place, our students, Afe Babalola students, and maybe the student from the public school, or maybe that will be another research that you will do going forward to compare the way the private university students, you can be nursing students, were adapted or addicted to social media and the smartphone, comparing with the public school. Having said that, it will be very good that some of your figures are displayed graphically, tables, so that we can look at it together. And most of the time, it will be good for that particular questionnaire that you adapted. You let us have that sense of the information. It's going to add value to your presentation. Having said that, I wanted to ask your conclusion or your recommendation. What is your recommendation to this? You are in the hospital setting. Having seen some of the results, the negative impacts, what is now your recommendation, not only to nursing students this time around, but to students generally on the use of smartphone?
Thank you very much. I think I answered the question before you posted it, because I say in my the final bullet on the slides, on the conclusion, I talk of digital policies from institutions, not only for nursing students, but other students as well, to guide that, there should be digital education on how they can be able to use, and then policy that will prohibit the usage of social media and smartphone while classes are going on, or while they are in classes. Then the healthy usage, just things that could promote the academics, not things that will further derail themselves. Although this is just what they call it, and one of the objectives of my research, one of the paper I am also planning to submit is factors that causes this. So some of them, it is a kind of negative vicious cycle. Because of stress, pressure from school, they want to use social media and smartphone to reduce the stress, as a way of escapism. And then, time over time, it becomes automatic, so that they use social media all the time. The issue of institutions, the study actually was carried out including public and private institutions in Benue State. Public and private schools in Benue State. In fact, I have Benue State University, Department of Nursing Sciences, Makudi College of Nursing Sciences, which is a private, and then a Missionary College of Nursing Sciences in Ka, which is was also part of it, and Benue State College of Nursing Science. However, sir, in my PhD, I'm trying to proceed with it. I'm trying to carry out an intervention, because remember I said this was a cross-sectional. So I want to carry out an interventional study where I'm going to get the data, not just subjective, but objective data. So an app is going to be developed to use in assessing that.
Thank you. Thank you. Thank you. We call on the next presenter. Next presenter, physical. Those that are going to be presenting virtually should hold on, so we can stay with you.
Okay, good afternoon, distinguished guests, lecturers, and my fellow colleagues. My name is Oganerukewe Umujapo Rivera, and I'm going to be presenting on the research titled The Correlation Between Cephalic Index and Forehead Wrinkle Onset Among Students of Afe Babalola University. So what is cephalic index? It is also known as cranial index. It is the ratio between the maximum breadth of the skull and the maximum length to the maximum length of the skull, a very useful anthropometric parameter utilized in racial variation. Then forehead wrinkle. There are lines or creases that form on the forehead due to intrinsic and extrinsic factors. Intrinsic factors being the factors that occur with or without the person being intentional about it. Even if the individual lives in a perfect environment, they will still occur. Those include genetics, hormonal changes, and hormonal changes. Extrinsic factors being external factors that accelerate wrinkling pattern formation. Then there are natural and artificial wrinkle. On the screen, we can see the bottom picture shows natural wrinkle, while the one on top shows artificial wrinkle. Natural wrinkles are the ones that occur without deliberate effort. This just saying that they occur when the person ages. Then artificial is deliberate, like through different maybe trauma or repetitive facial expression. Then importance of forehead wrinkle. Why forehead wrinkle? Forensic importance. With forehead wrinkle, you can use it to do facial identification. You can also use it to do age estimation, because the depth of forehead, the depth of the wrinkles can be used to quantify age. So it can be used for age estimation. For aesthetics, now this is the age of aesthetics, skincare, and we cannot neglect the fact that forehead wrinkle is part of it. For early detection of heart disease, they can act as low-cost, easily observable indicators of potential risk in adults. The aim of my study. This research aims to investigate the correlation between cephalic index and forehead wrinkle onset. These are my objectives, and furthermore into the research, I'm going to show you the results of these objectives. The scope of the study was limited to Afe Babalola University students, and inclusive criteria include students without forehead mutilation. They didn't have tattoos on their forehead. It was very visible. Their foreheads were clear. Students without face masks. There was no coverage. And students without heavy makeup. Materials and method. The sample size used for this research was 100 students, 90 female and 10 male, picked by random sampling. Between the ages of 18 to 25, sorry, that was a mistake on my part, between the ages of 18 to 25, Afe Babalola University. This study adhered to the Declaration of Helsinki's ethical principle, simply saying that there was informed consent, nobody was forced into this research, everybody knew about what the data was going to be used for. Data collection. So head circumference was measured with the aid of measuring tape. Forehead images were captured using this camera. Then height and weight were also taken. Then after which all these data were taken, estimation of anthropometric measurements like BMI and BSA was gotten for further evaluation. So on this picture, you can see that these are pictorial representations of the parameters being taken. Then data analysis. This data analysis of this wrinkle goes through a very technical process, but I'm just going to give you a bit of it. So the images are converted from JPEG to the quality there, just so that it could ensure good quality when processing. Then all images were processed and analyzed with this procedure in that lab, in Matt's work lab, in collaboration with the United States. Wrinkles and fine lines were detected using sober edge detector and canny edge detector. Then over to my results and discussion. So from the screen, you can see two graphical representations of cephalic index against gender and also age. So from my study, I could say that gender and age has no significant impact. And age has no significant impact on cephalic index. In the other figure, you can also see cephalic index distribution by BMI status. From this, I can say that BMI is related. It has a positive relation with cephalic index. Then distribution, forehead wrinkle, detected using image processing. I'm just going to highlight two figures here, A and B, because they are statistically significant. So you can see that the group of people that had wrinkles, they had relatively higher mean cephalic index, and also the group of people that had wrinkles had relatively higher BMI. I'm not focusing on BSA and age because it was not statistically significant. Then over to my objectives. The first objective, that's the correlation between forehead wrinkle onset and cephalic index. I'm just going to read this. There is positive, weak, and statistically significant correlation between cephalic index and forehead wrinkle. What I mean is that as cephalic index increases, the probability of having forehead wrinkle also increases. Forehead wrinkle correlation with age, with height, and with weight. So these are the expressions stood out. What is standing out in this graph is this figure. It is significant from looking at the p-value, that's 0.044. It is statistically significant and shows that weight has a relationship with forehead wrinkle onsets. Then the correlation between body mass index and body surface area on forehead wrinkling. Like I've stated before, when I showed the percentage of students that had wrinkles and BMI, that is also what's going on here. So the BMI, you can see that BMI is related to forehead wrinkle. It has a very small, but it is related. It is statistically significant, so it is related to forehead wrinkle. Then sexual dimorphism in forehead wrinkle pattern. So from my study, I could see that there was no association between sex and forehead wrinkle. In conclusion, the study of this correlation between forehead wrinkle, cephalic index, BMI, and BSC among students of Abuad shed new light on the complex relationship between these variables, revealing significant correlation between forehead wrinkle and cephalic index, and also between forehead wrinkle and BMI. So academic contribution and innovation. This research makes a significant contribution to forensic science, aesthetics, and diagnosis of heart disease by establishing the first documented forehead correlation with cephalic index in the West African population, filling a critical gap in regional forensic database. So it has not been established before. This has never been done in the West African population. Then it provides baseline anthropometric measurements between forehead wrinkle, cephalic index, BMI, and BSA. So recommendation. So a limitation to the study was the sample size, the age bracket, and the students of Afeb Valley University. So that being said, future researchers should expand in the sample size to include more Nigerian different ethnic groups and various age brackets, so that this will shed more light to the uniqueness of forehead wrinkle. So 100 students do not depict the population of Nigeria. It is not at all a good representation, but at least it's a stepping stone. So research perspective, this research work open new avenues for developing region-specific biometric identification system across Africa. The methodology can be used and can be adopted for other facial microbiometric research. That includes like eyebrow wrinkles and other research that could come after. So these are my references, and thank you for listening.
A round of applause. Question from students. Question. We need to be fast.
Good afternoon. I am Orakwe Ifeanyi from Department of Human Anatomy. I have a simple question to your methodology. You used 100 students, 100 participants. 10 were male and 90 were female. That's a huge gap. Is there any reason why we have that gap in the male and female population?
Did you get? Any other question? Okay, I have one for you. So, please, can you tell us what is the implication of this cephalic index and forehead wrinkle on the student? Like, what are you trying to achieve? What's the implication of the result that you just got?
So over to his question. The sample size stating 100 students, 90 female and 10 male. So I established the fact that the research was done based on informed consent. Nobody was coerced into doing it. It was a random sampling method was opted. So we just picked randomly, will you be interested in this research? And they came forward. That is why you could see the variation. It was not something that was particular to a particular class. It was just stated, and applicants came forward, and those were the applicants who had. Then, okay, so this research, it's the forehead. Now, this is a modern age. When we use where fingerprints are used, different DNA tests are used. So I was trying to show what forehead wrinkle can also do. what forehead wrinkle, it can be for facial identification, for age estimation. Those are just many of the numerous things forehead wrinkle can do. And it was used, and the research was done on Alpha Babalola University students, not limiting to students. That's why in my recommendation I said other researchers should go more and establish between different ethnic groups, and this was just to show the correlation. Is cephalic index related to forehead wrinkle, and we established that fact. Yes.
A round of applause for the presenter. The next presenter. The next presenter. Adegoke. Application. Do we have the slide, please?
Good afternoon, professors, doctors, and students in the house. I am Adegoke Juliet Ifeoluwa, and I'm here to present a narrative review on application of Internet of Things in investigating the factors that influence diabetes mellitus patients. You are welcome to the world of Internet of Things, where diabetic mellitus is having personalized care with information from data. This data is being analyzed, synthesized to generate a better outcome for patients. This is the presentation outline. It is no more news that diabetes mellitus is one of the chronic diseases, and it has a high prevalence, which is of global concern. And usually, the rate of the prevalence of diabetes mellitus has been increasing over time. It was estimated in the year 2024 that 530 million people worldwide have diabetes. And the commonest one is type 2 diabetes mellitus. That is why the focus of this review is on that. However, usually, self-care is important when it comes to diabetes mellitus to reduce morbidity and mortality rate. And the usual platforms that we use is a traditional model in the clinic, which relies heavily on clinic-based reviews and patient self-report. And it has been discovered from research that there are a lot of biases when it comes to the traditional models. And this calls for need to have a diabetic platform for self-management that will help patients to regulate their blood sugar, their insulin levels, and also control their physical activity. So, Internet of Things is an ecosystem of connected devices and softwares that transmit, capture, and analyze health-related data. And it has led to the development of intelligent self-care platforms. The objective is to assess the domains of self-care behaviors that apply to Internet of Things among type 2 diabetic patients, and also to identify the major factors that influence self-care behavior, to examine the ways in which Internet of Things technologies can actually support self-care practices, and also look at the enablers in Africa that can support Internet of Things. 10 articles were reviewed using three electronic databases, and the search was conducted according to PRISMA protocol, and priority was given to African studies. We have our search items, and the inclusion criteria are data that included Internet of Things from 2014 to 2025. African studies were included. Then the exclusion criteria are non-Internet of Things related studies, non-English publications. The data was extracted and assessed for eligibility. So these are the papers that were included in this study for this review, and that shows various technologies and modality for management of self-care in type 2 DM patients. Going to the results, self-care behavior in a type 2 DM patient, the key concepts in that area, they are glucose monitoring, healthy eating, physical activity, behavior maintenance, and medication adherence, according to Massin et al. And some researchers have also studied digital tool adoption in self-care, and they found that these devices are actually effective, but the adoption by the clinicians, the physicians, is the problem that we have. Then looking at the factors that influence self-care behavior, we have economic factor, which is the paramount. because of finances, many people cannot adhere to self-care practices. Also, we have a genetic lack of defense. Level of education is also another factor that affects self-care behavior in type 2DM patients. The emotional health of an individual, the cultural adaptation of the treatment also affect type 2 self-care behavior. How Internet of Things can be used in supporting patients with type 2 diabetes mellitus. We have a lot of Internet of Things facilities. We have smart pill boxes. We have some apps that are linked with medication reminders for adherence. We have chronic glucose monitoring devices that produces glucose data, which can be aligned to their meal times, their activity, and it also help patients to identify the choices of their diet. We also have wearable accelerometers that help to monitor physical activities, or phone sensors that helps to monitor physical activities and patterns, which will help in the glucose control. We also have smartphone assisted food logging, cameras that help to capture diet content of patients. We also have IoT platforms that actually study the ecological momentary assessment. It can also study the mood of patients, because researchers has revealed that mood of patients usually affects their adherence to medications. This is an IoT-based monitoring platform where informations are gotten from sensors, and it uses internet facility, 4G, 5G network. It goes into the cloud layer to compute the results, and it will bring out, it carry out an investigation, it will extract the data, and we now send this information to healthcare providers, for either the healthcare providers and even the patient, depending on what the patient wants. So in Africa, there are factors that enables IoT uptake, like the widespread use of phone mobile, which presently there's almost everybody has mobile phone, and this is one of the enablers of internet uptake for diabetes in Africa. Also, we have growing researches that are focusing on low-cost technologies, because one of the challenges of Internet of Things has to do with the cost of these internet facilities. But there are researches going on for low-cost technologies, and also the government is interested in digital health now. These days, we have been talking about digital health since morning, and there's also enhanced connectivity in most cities. Even in some rural areas, there's connection in those areas. Those are things that enables Internet of Things uptake in Africa. The gap in literature, there's limited evidence in Africa, as most of the evidences gotten were from developed countries. Also, another gap that was discovered was that there's scarcity of integrated IoT solutions. Most of these internet IoT solutions that were being used usually does not combine most of these components of Internet of Things. They usually go alone in terms of mobile applications, SMS, phone calls, and so on. Then digital literacy and usability considerations is also important, as the digital literacy has been discovered to be low among Africans. Summary. The review studies collectively highlight the transformative potential of Internet of Things and their role in empowering patients, improving self-care behaviors, and also to improve clinical outcomes. However, there are gaps that was reviewed in the study, and there's need for integration of mobile health tools into practice. In conclusion, IoT technologies present a powerful tool for understanding and improving self-care behavior among type 2DM patients. However, there are challenges like cost, infrastructure, digital literacy, and governance must be able to be addressed IoT so that it can be scaled up. Recommendations: there should be promotion of digital health literacy initiatives. There should be integration of IoT into our clinical practice. There should be enhanced data privacy and security, which has been discussed during the plenary session earlier as one of the lawsuits that can come out from using digital tools. Then there should be expand research and access to marginalized group, like patients that does not have access to phone, or pediatric patients. And there should be advanced longitudinal and scalability research. These are my references. Thank you.
Even while we are still eating, let's clap. Well done. Internet of Things in Type 2 Diabetics Management. Do we have questions from students? It is not easy to come to the stage to present. For coming to the stage, many people have information, they will keep it to themselves. So for you to come up stage to present, a round of applause once again. This is a review paper, putting work that has been done together over a period of years. I think 10 years, 11 years, and using meta-analysis to synchronize and bring out information. Do we have questions? Okay, just question from the people sitting. Or the okay. Wait, can you take your question now? Please listen to the question. Go ahead, sir. Adegoke Benjamin. We cannot hear you. We can't hear you.
To review like the papers that were originally downloaded was not mentioned, and I think it's necessary. Number two, the inclusion, though you mentioned the terms that you use for the search, inclusion and the exclusion criteria also will need to be emphasized before you now report the final number of hours that you use to arrive at the presentation. You're giving us this data will assist not only the listeners, but also other researchers that want to do anything on review papers. Thank you.
Much. It's just for you to prove that some of the paper that you downloaded were not seen or cited.
It was on the table. It was on the slide. At first, the papers that was downloaded was 5,077. After shuffling and using all inclusion and exclusion criteria, that was when we come. That was when the 10 was actually reviewed with the exclusion and inclusion criteria. I have the picture on the slide.
Just note that, go and look at it again, and going forward, so that people can okay. Contribution, sir. We call on the next presenter, virtual presenter. All right, okay. We have who is the last presenter or physical person? Yes. Physical. No physical again, so all of them are virtual now. Okay. The first or the second, we've had one virtual presenter in the morning. Now we want to entertain the second presenter, who will be presenting virtually. title page. Title page, sir. All those that are presenting virtually should stay put. We will take them one after the other. We'll entertain one or two questions and we can close this section.
Hello, sir. Can I present?
Go ahead, sir. Thank you.
Thank you very much.
10 minutes for your presentation, sir.
Okay. Thank you for the opportunity. Adegoke Bio, presenting on behalf of myself, Ayola, Michael, and Prof. Anyachi. I'm presenting on causes, management, prevention, and awareness of devices used for monitoring fever in southwest Nigeria. This is my presentation outline. Malaria is one of the most dangerous sicknesses in the tropical region. And because of this, continuous monitoring of core body temperature can assist in noticing and approaching illness. Statistics has it that causes of death in Nigeria is as shown in this chart. It reveals that malaria is second to the most popular causes of death. And we know that in malaria, rise in temperature is one of the pointers. Though there are many pointers like the headache and feeling confused, feeling tired, tiredness, being sick, tummy pain, and all the rest of them. But most importantly is the temperature rise. And in the measurement of temperature, temperature can be measured either from oral cavity, from rectal, from axillary region, from forehead, from the ear region. And when we talk about temperature discrepancies, we have hyperthermia and we have hypothermia. The hypothermia can be mild, can be moderate, can be severe, and can be profound. This research was conducted to get the awareness of clinicians and the general populace about availability and possibility of employing fourth generation industrial revolutionary tools where we have the Internet of Things, IT, artificial intelligence of medical things. Two sets of instruments were developed. One for the clinicians and the second one for the general populace. The questionnaire for the clinicians, there are two sections. One of each, section A, deals with information about fever, while section B deals with about data of the respondents. The clinician has 14 questions about malaria or fever, while they had 8 questions that have to do with their our data. The general populace attempted 24 questions. These are close-ended questions. And also they had 5 questions that were to capture their biodata. After the refinement of the questionnaires, they were converted into Google form and then administered online. This is the front page of and the link for the instrument that was administered on the questionnaire on the clinicians, where we have the medical doctor, nurses, lab technicians, and all the rest of them. This is the front page of the questionnaire that were administered on the general populace. The general populace cover Osun State, Ondo State, and then Oyo State. The same thing for the clinician. This is the result. For the clinicians, we had 8 respondents because it was an online, it was administered online. But for the general public, we had 94 respondents. In that table is the gender distribution of the respondents for the clinicians and also for the general populace, and the graph representing their demographic representation. Now, the need assessment from the questionnaire administered, we discovered that only 50% of the clinicians are aware that it's possible to administer healthcare services online with the present industrial revolution. From their response, about 87 of them, 87.5%, they want post-clinical visits. That means the visitation of a client to the hospital after medical treatment, they can't is very important. And also, all of them, all the clinicians agree that fever is a forerunner to many of the health issues, whether you are having high blood pressure or you are having what have you, or diabetes. Temperature, your temperature will first rise. All of them agree to that. About the general populace, it was discovered that many of them were not aware that it's possible to have your case attended to online or virtually, as reflected in the percentage. 73.4% and found that they were not aware, while only 26.6% are aware. About roughly 57.4% at one time or the other measured their temperature by themselves. And many of them are always troubled when they have a rise in body temperature, and this gives them a lot of concern, as reflected both in the table and in the chart. Discussion. Let me jump this because of my time. 25% of the clinicians stated that they were aware of the devices for monitoring body temperature. 25% were aware of infrared thermometer. 50% were aware of any new technology for temperature measurement. Meanwhile, 50% of the clinicians recommended post-clinical visit of client. 25% wanted patient to report. 12.5% wanted designated nurses, and while 12.5% were neutral about any remote client monitoring. 26% among the general population, 26% were aware of devices used for temperature measurement. 37%, 37 and 15% were concerned about their temperature, respectively. And the general populace indication of location of measurement of temperature revealed 59.6%, 23.4%, 3.2%, and 13.8% for forehead region, axillary region, oral region, ear region, respectively. 23.4% were aware of digital thermometer. 73.4% were not aware of any device.
Your time is up.
4.3% were aware of advanced means of
Your time is up, sir.
temperature measurement. And in this
Conclusion, sir.
regime, we are in the 4th generation industrial revolution, and advanced countries are already moving into the 5th industrial revolution. It is high time that both the clinicians, people that are practicing in the medical line, should try to make sure that we read more, we get more exposed, so that we can meet up with the global development. And these are recommendations. All respondents were interested in measurement of their temperature. Majority are not aware of any technology that can provide real-time temperature data.
Thank you, thank you,
Design
thank
and
you,
development of an
thank you. A round of applause for the presenter online.
measuring device
Thank you,
will
thank
be a
you,
worthwhile effort and innovation.
thank you, thank
And
you,
digital
thank you.
literacy is necessary.
Thank
These are
you.
some of my references. Thank you for your time.
Thank you so much. The title page. Do we have any question?
Thank you, sir.
My own question, please, before I saw in one place you said 2 physicians, 25% are aware of the use of device for measurement of body temperature. I think that's figure. Are you saying out of the data that you came out with in the research, because that figure seems to be very low for physician not to know the device, or you just stated just 2, very low as far as I'm concerned, on the use of the device for the measurement of body temperature. Thank you.
Yeah,
just take the question down. Take the. It's just anyway. It's not a question. It's an observation for my own side. Question.
Good evening, all.
Please speak up.
Thank you, Mr. Presenter. Can you please go back to your first slide? The title slide.
Okay. Okay.
In your title, just go back to the slide, the first slide. Share your slide.
Okay.
The title.
The title.
Yes, speaker.
Okay, thank you.
So in your title, you say the course is management, prevention, and awareness of the devices used for monitoring of fever in Southwest. However, your second slide, you make mention of malaria. So I need the third slide. So are you assessing how the health workers assessing the detecting the fever, or you are assessing your study is based on assessment of various types of fever? The fever can be either unknown, fever can be unknown, fever of unknown origin, or can be fever of known origin like malaria and whatsoever. But your title is not specific. And then in which kind of category of health worker you want to assess this, assess the knowledge of management, causes, and the rest. I think you need to specify in your title.
Okay. Can I respond now? Is that all?
Go ahead, sir.
Thank you very much. Thank you. The second questionnaire. Actually, the title is talking about assessment of fever, which generally in the clinical line means rise in temperature that is beyond the normal body temperature. And generally, it is accepted both in practice and in literature. When anybody has a rise in temperature, we say he has a fever. And we know that fever is more related to malaria. So that's the essence of emphasizing malaria in the second slide, which you refer to. But meanwhile, your suggestion will be taken into consideration concerning the title. Then for the first questionnaire, when we were administering the questionnaire, we actually administered the questionnaire in UC. And because of their tight schedule, and some of them were not open, they were not ready to release their detail. In fact, the little one we had, one of the principal officers had to intervene before they could attend to us. So that's the reason why the population about the clinicians were very low. And also the duration, because this research was conducted to confirm the need assessment for development of a remote temperature monitoring device. Thank you very much.
Thank you. We call on the next presenter. The next presenter.
Over to you, moderator.
Thank you so much.
Hello, sir. Hello.
08 should come on board. Thank you, Adegoke Benjamin. We appreciate you.
Hello.
Thank you so much. 08 should come on board.
Thank you very much.
Yes. Thank you. And
yes.
After 08, we will entertain the last person, 003.
Good afternoon. Can you hear?
Can you share your slide with us?
Yeah.
Yes, we can hear you.
We can hear you. Can you share your slide?
Okay.
Perfect. Thank you.
Okay, thank you.
Yeah,
We all are.
we can view it now. We can see it. You have 10 minutes to deliver your presentation. Go ahead. Thank you.
We all had to stay up late due to various circumstances like night shift, deadline, and we can attest to the fact that we tend to crave snacks during this period or opt for quick meals which are highly processed. I am Tanimonu Rabara Christian University of Human Physiology, and I'll be speaking on the topic the effects of high salt diet on sleep deprived adult male with star rats. Here's my outline. High salt diets and sleep deprivation each have severe implications on our metabolic health. Research has shown that the average salt intake in Africans or globally is about 6 to 10 grams, while the recommended WHO intake is just 2 grams per day. Now, salt is found in our breads, our snacks, literally everything that we eat, and this leads to end organ damage. And salt is also found in our beverages. It leads to end organ damage, lipid metabolism disruptions. Now, if we look at this second slide, it shows us the effects of sleep deprivation also. Sleep deprivation causes severe reactions like memory lapses. It could lead to hallucinations. It could lead to severe heart diseases. Now, this research wants to show the implications of these combined stressors and how it's going to interact to influence our lipid profiles. The aim of my study is to determine the effects of high salt diet on lipid profiles in sleep deprived adult male with star rats. Now, my objectives is to determine the total cholesterol level, the triglyceride level, the low density lipoprotein concentration, and the high density lipoprotein concentration. The method used during this research was to acquire 20 rats, 20 healthy rats, and we left them to acclimatize for a period of 2 weeks before commencement of this research. After that, we randomly selected them into 4 groups. Group 1 was the normal control group, which they were just fed pellets, normal pellet food. The group 2 were the sleep deprived group. They were also fed normal pellet feed but sleep deprived. The group 3 were the high salt diet group, while the group 4 was the sleep deprived and the high salt diet group combined. Now, the way we sleep deprived these rats was by placing them on a modified multiple platform, and we partially submerge this platform into a cage filled with water. So in case the rats sleep, they will fall inside the water and have to go back to that the raised platform to stay. And the high salt diet was done by molding the salt into the feed with water. The salt and the feed were measured so that we could get an estimate for the measurement. The estimation of total cholesterol, triglyceride, and high density lipoprotein was estimated using agape assay kit, and the low density estimation was done by using the concentrations of triglyceride, high density lipoprotein, and total cholesterol. Now, in my method, when we fed the rats with salt, we molded the salt that was given to the combined group and sleep deprived them also. In the cage, the sleep deprived cage is built in such a way that the cover has a net-like structure where you can place a molded feed. So when they are there, we sleep deprive the rat for about 20 hours and we allow them a recovery period of 20 hours for a period of 6 weeks. This research was done for 6 weeks. That means the sleep deprivation lasted for a period of 21 days. Now, my results. This graph shows the result of high salt diet on total cholesterol levels in sleep-deprived adult male with star rats. And we can see in this graph that the control group exhibited the lowest total cholesterol levels, and it serves as the baseline for our comparison. A marked increase is also seen in the high salt diet group, which indicates a statistically significant rise compared to the control group. And we can see further elevations also in the sleep-deprived group. which was significantly higher than both the control group and the high salt diet group. Now, the combined group, which is the sleep deprived group and the high salt diet group, showed the highest total cholesterol levels. And this is significantly different from all other groups. This second graph shows my results for triglyceride. Now, this graph, the control group recorded the lowest triglyceride level. All the experimental groups, which is the high salt diet group, the sleep deprived group, and the combined group, they demonstrated a significant increase compared to the control group. However, there is no significant difference among the high salt diet group, the sleep deprived group, and the sleep deprived plus high salt diet group combined. Now, the third graph is my result for high density lipoprotein. And this graph shows that there was an inverse pattern relative to the other total cholesterol and triglyceride results, because we all know that high density lipoprotein is the good cholesterol in our body. The control group shows the highest high density lipoprotein level, and this reflects a healthy lipid profile. A significant decrease was observed in the high salt diet group, with further reduction in the sleep deprived group. The combined group had the lowest high density lipoprotein level, significantly lower than all the other groups, and these results indicate a progressive decline in high density lipoprotein levels. My fourth graph is showing the result of low density lipoprotein, and we can see that low density lipoprotein levels increase progressively across the group. The control group recorded the lowest low density lipoprotein level, which increased moderately in the high salt diet group, the sleep deprived group, and it showed a marked elevation also in the combined group, which is the sleep deprived plus the high salt diet group, which is significantly different from the control group. The highest low density lipoprotein group, which is the combined group, is significantly different from every other group. And that is to show us that low density lipoprotein, which is the bad cholesterol in our body, has an effect. Now, in conclusion, this research shows that the effects of high salt diet and sleep deprivation, which affects our lipid profile, is drastic to our health, as our little habits can sum up to greater implications like metabolic syndrome. I recommend that we as individuals avoid salt consumption in high percent, and that factories or food factories tend to look at their nutritional values and reduce the salt content when producing most of the things that we buy, like snacks. Here are a few of my references. Thank you.
Thank you. Thank you. A round of applause for the presenter. Do we have questions?
Hello. Can you hear me?
Yeah, we can hear you.
Yes.
Questions?
Please, can you still see my slide?
Not yet.
Hello? We just have one question so that we go to the last presenter. Questions? Do we have questions? High salt diet on lipid profile in sleep deprived adult male Wister rats. Questions? You have a good slide. Your presentation was well delivered. However, the error bar was not showing on your graph. Those bar charts.
Sorry, please come again.
Error bar was not seen display on the bar charts.
Robbers are there.
Eroba. Okay, it is because I can see you are comparing 3 groups or 2 or more groups. So statistical significance, that particular tool that you use, we should be able to see. It brings about our ability for us to see the confidence interval.
Hello, please, I can't hear you.
Just a comment, not a question, actually.
Okay, thank you.
Thanks for presentation. We call on the last presenter. Last presenter. Thank you, thank you. 003. 003. Come on board. Drivers of food production and their implication for health outcome in West and Central Africa. Adebola MK. Do we have Adebola on? 10 minutes for Adebola.
Good afternoon, everyone. My name is Adebola Matthew Kennedy.
Okay, thank you.
A PhD candidate from the Department of Economics at Abuad-Cmhs University. I am pleased to present my study titled Drivers of Food Production and their Implication for Health Outcomes in West and Central Africa. Now I'm looking at the food production plays a major role in shaping population health. That is, food production is essential for good health. However, many countries in West and Central Africa still struggle with serious food challenges, including low productivity, poverty, and food insecurity. These issues contribute to poor health outcomes, such as low life expectancy and high infant mortality. Objectives. We have 3 major objectives: to identify key determinants or drivers of food production, to examine how food production affects life expectancy and infant mortality, to assess whether poverty mediates the relationship between food production and health outcomes. Methodology. The study uses panel data from 2000 to 2023, covering selected countries across West and Central Africa. The data sources include World Bank Development Indicators, Food and Agricultural Organization, Statistics, Demographic and Health Survey, United Nations Development Program. And again, some of the key variables used are land, GDP, employment, expenditure, import, interest rate, neutral society, literacy, and we also have some key variables like food productions, poverty, life expectancy, and infant mortality. Now, the analysis. To analyze data, the study used panel regression methods such as feasible, generalized least squared, and discrete estimators. This is used to ensure we have a reliable result. And poverty also serves as independent and mediating variable. Now, result. Agricultural land, GDP per capita, neutral society emissions, and literacy all increase food production. High agricultural employment reduces food production, meaning many workers are now very productive. More food production improves life expectancy, and more food production also reduces infant mortality. Poverty reduces the health benefit of food production. In simple terms, even when food production increases, poor countries do not enjoy the full health benefit. There are also regional differences, regional variations. In West Africa, GDP growth and government spending matter more. That is government expenditure. While in Central Africa, land expansion and literacy play a bigger role. Policy recommendations. Based on these findings, the following actions are important. Increase agricultural productivity through better technology and support. Reduce poverty so that people can enjoy better health outcomes. Invest in education and literacy, which support food production. Use land more efficiently and sustainably. Encourage regional cooperation since the factors differ by region. In conclusion, food production has a positive impact on health. It increases life expectancy and reduces infant mortality. But poverty weakens this good effect. To improve health in West and Central Africa, country must boost food production and reduce poverty at the same time. Thank you for listening. I am happy to take your questions.
We have come to the end of this session. For those that have been able to wait from the beginning to the end, we appreciate you for your patience, for your endurance. Hope to see you tomorrow. Thank you.
Hello? 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 On behalf of the LOC, once again we want to thank every one of us that graced this occasion. We really appreciate your participation. Today is not the end of it. It will continue tomorrow. I will encourage every one of us to please be in attendance as early as 9 a.m. We want to start our plenary session and round up immediately after the plenary session. We move on to our oral presentation. Tomorrow we are going to entertain more oral presentation. So in order not to drag it or not to waste our time, I urge every one of us to kindly submit our poster our PowerPoint presentation to the dedicated email address. Please, if you have any colleague that is not present here, kindly relay the information to that person to submit the PowerPoint presentation to the dedicated email address. That is where we can easily track, download, and put into separate groups. Tonight, we are also going to divide us into separate groups. Please kindly check the WhatsApp group so that by the time we come here tomorrow, we know the particular group where we are going to make our presentation. Once again, I want to congratulate every one of us that are here. I know we have gained a lot and we will continue to learn until we continue to learn as long as an academia. Thank you once again. I really appreciate you. So at this point, I will encourage every one of us to please be on our feet as we are about to sing our Abuad and national anthem.
Abuad we come, oh Abuad we come, Abuad we come, oh Abuad we come, founded by a fan, Babalola, a believer in industry and determination, a unique environment with aesthetic structures, a Beckoning University, delivery unequal, design for high quality education to mold character and infuse knowledge how to lead others. Proud of Abuad, they launch a path to excellence with determination and faith in our broad philosophy of industry, service and character. Our future for greatness and excellence is assured. And excellence is assured. And excellence is assured.
Nigeria, we hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians old and proud to serve our sovereign motherland.
Usman Bello. Usman Bello. What do you need? What's the question? We have come to the end of today's program.
Hello, I can hear you, ma.
We have come to the end of today's program. See you tomorrow. Thank you.
Yes.